Hello once again. I'm looking for my second presenter. I do not see her name, so just allow me to check. Dr. Moali, are you here?
Yes, I'm here. Thank you.
Okay. Thank you very much. So now we can start. I see that Dr. Smith is also here. She might just be joining audio. She had indicated that she might be late. But since she is here, Dr. Smith, you have come right at the opportune time. This is your time to start the meeting.
Oh, thank you, Wisi. Thank you so much. Good afternoon, everyone. Thank you once again for joining us. We have this webinar every Friday to discuss COVID-19 issues and
every Thursday.
Every Thursday. What? Every Thursday. Sorry. To discuss COVID-19 issues and topics of interest. So today we are fortunate enough to have representatives from 2 DHMTs who will be giving us updates from their DHMTs. So if you want to be added to the mailing list to receive the invitations for these webinars, you can send your email to vindaba@globalhealth.rutgers.edu and you'll be added to that list. These sessions are recorded. You have the opportunity of viewing them on the YouTube page where they are saved. You also have the opportunity to look back at other sessions that you might have missed previously. We also have the government portal, the COVID-19 government portal, where you have an access to different guidelines on so you just go to that URL and then you click on document library and then you'll be able to have access to those guidelines. Next slide, we see. Okay, like I mentioned, today we have representatives from DHMTs from the Ngami DHMT as well as the Okavango DHMT. They'll be giving us an update of their responses to COVID-19 in their DHMTs. And this is a time for us as well to learn from them, as well as maybe point out areas of improvement that they may have to look at. So the first presenter will be Dr. Sandra Maripe, who will be representing the Ngami DHMT. Okay, Dr. Sandra Maripe is a family physician who believes in primary health care as the core community health matter. She holds a new role as of October 2020 as the acting Ngami DHMT coordinator, working under the Ministry of Health and Wellness. She provides overall supervision and administrative leadership on all patient care in the DHMT. Prior to being the acting DHMT coordinator, she was the head of preventive services, coordinating programs such as malaria, SR therapy, TB, and child health. She's also the vice secretary to the Botswana Association of Family Physicians. She has also worked with non-governmental organizations that mentor and empower the girl child. Sandra holds a master's in family medicine from the University of Botswana, which she completed in October 2017. Dr. Maripe, I'll hand you the mic over to you now to give us an update from your district. Thank you.
Thank you. A very good afternoon to you, colleagues. I'll be taking you through the Ngami DHMT COVID situational updates. So we'll take you also through the vaccine rollout updates, how we are faring in our district. We see they are not moving from this side. So this will be the outline of my presentation. I'll take you through the district profile. And like I said, then we'll take you through the COVID-19 situation update. I'll also ferry you with our successes, our challenges, and how we are also mitigating the challenges. So this is our district profile. Today we are the presenters, and previously Chobe has also presented. We are bordered by Chobe, and also on the northwest we are also bordered by Okavango DHMT and Bokwena DHMT. So Maung is the main headquarters for the DHMT, and my slides are not moving from the side. We are covering a square area of 86,000 square kilometers, and we have got a population that has been projected for 2021 to be standing at 110,000. We have a total of villages that we cover in our district, and we have 1 district hospital. We have got 12 clinics, 17 health posts, and we also service quite a number of mobile health stops. And this covers a total of 92, and Maung being a tourism hub and a gateway to the Okavango Delta. We have quite a number of safari camps that we also have to visit quite often. And we are currently standing at 55 safari camps that we visit in the district. And we also have 3 isolation centers that we are currently utilizing. The first one being the district hospital that I mentioned, and we also have got 2 sites being wildlife and Maung Rest Camp. We also have Maung International Airport, which is probably one of the busiest airports in Africa, which is our main port of entry in Maung. We work together with private clinics, and we have a total of 17 which are in our district. So in terms of the data, we had our first case in June 2020, and cumulatively we have so far had a total of 6,049 cases. We are currently standing at 398 cases, and unfortunately we have had 135 deaths within our district. Maung, being the main village, is currently our epicenter for the COVID positive cases. So in relation to the status of our isolation, the majority of our clients, they're on home isolation with a total of 373. We have Botswana Wildlife Training Institute, which is currently holding 15, and Maung Rest Camp, which is a 50-bed capacity, which was donated by an NGO to the district. So we are also holding 11 patients there. We have the hospital, which is our main high dependency unit, which is a 32-bed capacity that we utilize mainly for patients that are needing oxygen. And we are currently having a total of 12 patients. So this is the picture for Ngami DHMT. Like I mentioned, our first case was in June, and all was well. That is when we went into our second wave, and we reached our peak in February at 676 cases. And we have currently been experiencing our third wave now in July, and we were hard hit with a total of 2,320 positive cases. And as of 23rd of August, we are currently having a total of 929 clients, which were recorded in the month of August. In terms of deaths by age, We have also noted that the pattern is similar with the national level. The majority of our cases are those who are aged 55 and above. And over the last few months, we have also seen quite a number of the younger population also dying due to COVID-19. So these are our numbers, as you can see here on this graph. And we have had even babies who have died of COVID-19. Our case fatality rate remains high in the district, and as per the fatality rate, we are standing at 2.2%, and this is the highest case fatality rate comparing with the other districts. Fatality rate remains high for those who are aged 55 and above. It is currently standing at 18%. This slide, we are highlighting healthcare workers who are also affected due to COVID-19. We have had quite a number of healthcare workers having to go into isolation once they had COVID positive. And this, we are trying to highlight that this is also affecting service delivery to our communities, as we have these officers being held in isolation. So we have had a total of 241, and of that number, 15 were doctors, 109 were nurses, and the other balance is for the other cadres and the allied health. We have had a total of 8 deaths, and from these deaths, 3 were doctors. And maybe of highlight is to say they were all coming from private, and we have lost 3 nurses, 1 hospital orderly, and a driver. Next slide. I mentioned earlier that Maung is the gateway to the Okavango Delta. We are having Maung International Airport as our point of entry into the district. And we have also been doing surveillance at Maung International Airport, and we are also able to pick quite a number of positive cases through the rapid antigen testing. And the numbers can clearly be seen there on the table. And when we were reaching our peak in July, we recorded 8 positive cases that were picked from Maung International Airport. We are currently experiencing a national shortage of testing kits, and this has also since affected the surveillance that we are currently doing at the port of entry. But for those who come with an expired 72-hour valid test, we do the PCR and keep them in quarantine until the results they are out. So to date, we've been able to do 6,272 tests at the Maung International Airport. So I'll now take you through our COVID-19 vaccination campaign, which we started on the 26th of March, 2021. We started with AstraZeneca, and we have currently fully vaccinated 2,353, and we have recently received the second doses for those who did not have their second dose. We are also having Sinovac in our district, and the second dose vaccinations are currently ongoing. We currently have 5,595 that are fully vaccinated, and for Pfizer, we are currently having 362. We received 5,200 doses of Johnson & Johnson last week, and at the time I was preparing the presentation, we had vaccinated 2,566, but we are now currently standing at 4,000 with only a little bit of over 1.2 doses, which they are currently utilizing. Of this number, we have vaccinated a total of 2,216 teachers, as there was also a special dispensation for the teachers. We have vaccinated 1,071 healthcare workers. In terms of the performance of the overall target, for those who are 18 and above for Ngami, we are currently standing at 15.2% coverage. Next. Our successes, we have a fully functional and an active district Emergency Operation Committee, which is chaired by the DC. And it's through this committee that we have collaborated with NGOs and other government departments. We also stakeholders. I talked about Mau Rest Camp, which was donated by an NGO called Project Sanitize Mau. We work with the Botswana Wildlife Training Institute. We were also donated another testing site, which is called the Power Station by Project Sanitize Mau. We are currently having 6 vehicles in addition to what the DHMT has. And these are from various government departments. We also have got 4 vehicles from Project Sanitize Mau, and these vehicles have been with us for over the last 6 months for various COVID-19 activities. We are working very well with the BDF. They have donated 2 nurses, which have been working fully with the DHMT now over the last 6 months for the COVID activities. We have private facilities that have come forth to assist with vaccinations, and we have also actually given others vaccines so that they can vaccinate at their sites. We also have another NGO, which is called Maung Business Club. They donated 10 volunteers to work in various testing centers and vaccination sites, and they actually assist with their allowances. And we also had another 5 from Project Sanitize Maung, and this very same club also donated 150 chairs, as they had noted that most of our clients, when they come in large numbers, others have to wait for quite some time before they get assisted. Prior to the 3rd wave, Gaolathe Hospital was functioning as a 16-bed, and we were able to expand it to a 32-bed capacity at the time when we actually needed more beds for most patients that needed oxygen. The Ministry of Health and Wellness has also since given us 6 new ambulances, of which 2 are now being fully utilized for the COVID-19 activities. And we also believe that despite the challenges, we have been able to successfully carry out the COVID-19 vaccination rollout. For our challenges, the first one is the limited supply of vaccines, because most Botswana are ready and they are waiting for these vaccines. We continue mobilizing our communities, but as soon as these vaccines run out, it kind of interrupts the momentum within the communities and the officers. We are also having rapidly increasing number of COVID cases in healthcare workers, like I mentioned earlier, and this has since also affected our service delivery. I remember at one point our lab had 7 officers who were in isolation, and that affected the turnaround time of the results. We have a limited capacity for facility isolation and quarantine. Like I mentioned, the majority of our patients are on home isolation. We are also noting non-compliance of COVID protocols, and this is not only for individuals, but also for some institutions, business premises, government institutions. People are not wearing masks appropriately. At retail shops, we do not maintain social distancing. We also noted faulty thermometers as we move around doing the random inspections. I think I talked about shortage of resources. We currently don't have testing kits. We need more HR, particularly in terms of nurses, doctors, and laboratory personnel. And we have also noted that the COVID response is continuously competing with other programs, and sometimes it hinders smooth service delivery. Way forward, with the critical shortage of the vaccines, we are continuously requesting for test kits from other districts who may be having more than what they may need. We are currently able to at least test those who are symptomatic. I mentioned that in July, we also expanded our COVID ward from a 16-bed to a 32-bed capacity. And due to the limited supply of vaccines, we are continuously adhering to the current National Vaccine Deployment Plan, of which we are vaccinating according to age, those who are 45 and above, with the age waived for healthcare workers and recently for the teachers. We are continuously doing infection prevention control checks, and these spot checks are not only done in our health facilities, we also assist our environmental health team from council. We work together with police to do this spot checks, be it in business premises, churches, social gatherings, like funerals. We are also advocating as a district for an ICU capacity, because we are continuously having to refer patients to Gaborone, having to travel a distance of 1,200 kilometers, which has not only proved to be expensive for the government, but sometimes it also has health implications for our patients. We are continuously engaging the district leadership, both community and political leadership. We are working together with NGOs, the private sector, to fighting against COVID-19. Lastly but not least, we are continuously advocating for more resources together with the Ministry of Health and Wellness. I think with this is where my presentation ends, and I deliberately put that Nyeletsa malaria logo because we are amongst the 6 endemic districts within the country. And as we are about to enter into the malaria season from October, we are going to have to work parallel with the COVID activities together with the malaria activities. We do indoor residual spraying. Malaria, as we know, it is also a public health concern. We have to do contact tracing, and this also affects how we work as a district, because we have to do all these things with the same resources that we have. So this is where the presentation ends. Thank you.
Dr. Maripe, thank you so much for sharing your experiences in the districts, your challenges, and your wins so far. Before we can go on to any discussions, we will now have a presentation from Dr. Bokwena Moali, who will be presenting on the update from Okavango DHMT. She's currently the DHMT coordinator for the DHMT Okavango. She graduated from the University of West Indies Mona campus in Jamaica in 2009. She also holds a master's in public health and health management from that campus, which she completed in 2016. She completed a fellowship in global health leadership through the University of Botswana and the University of Washington, Seattle in 2018. She is currently enrolled with AMREF Africa and Botswana Open University, currently studying leadership management and governance for senior policymakers. Her main interests are in health system strengthening, particularly in managing change and building capacity for public health emergencies. So we'll now have a presentation from Dr. Moali. Thank you. Hello, Dr. Moali.
Yes, good afternoon, everyone, and thank you for the introduction. So I'll be presenting our DHMT COVID-19 report, focusing on our successes and challenges. My slides are not moving. Okay, for those who don't know where Okavango DHMT is, Okavango DHMT, or the sub-district, is located in the northwestern part of the country, most northwestern part of the country, and it has a projected population of about 71,727. We have 29 health facilities and 2 isolation centers with a total capacity of 22 beds. We don't have any facility quarantine at the moment. We have 2 border posts. One is open, which is Mohembo border, but the other one has been closed since last year, March, which is the Dobe. We have about 34 villages that are gazetted in the district, and most of our villages are along the Okavango River, and some of them lie in the Okavango Delta itself. So our district response is spearheaded by the District Emergency Operations Center, which comprises of us, the Secretariat as the DHMT, through our Public Health Emergency Management Committee. We also sit with the Law Enforcement Committee and the same committee and the Environmental Health and bylaw from local government. And on the ground, we have the Village Emergency Operations Centers, which are chaired by the school heads, and the courses are part of it. We meet every Wednesday, if possible, where we present our reports, deliberate, and come up with interventions for appropriate response for the district. So from when COVID-19 was declared a disease of public health importance, we have cumulatively registered 3,448 cases, of which 95 are active. 3,317 are recovered. We repatriated 4 to Namibia. Unfortunately, we lost 32 patients, and our case mortality rate is at 0.009. So of the 95 cases, 92 are on home isolation, and we don't have anybody at Gomolemo Primary Hospital isolation now. And at JP, during the compilation of this report, they had 3 patients, which is only 15% occupancy rate. So this illustrates our weekly trends. I must say that we registered our cases last year, our first case last year in October. And we were doing well until December. And then we started noticing a sustained transmission. Before the 25th of December, we had 10 cases. And beyond that, we started noticing a sustained transmission in the district going into January. And our peak was in week 5, where we registered 212 cases. And we continued to register most cases in February until we noticed a downward trend in April. In our case, we had a surge consistent with the third wave that was affecting the whole country. So on week 29, we registered 447 cases, but we continued to register a lot of cases, but on a downward trend until week 34, which ended on the 21st of August, where we had 77 cases. I must say that even though I do believe that there is a downward trend in the number of cases for COVID in the district, this could also be compounded. 7 might not be accurate for the actual number of cases that we have for the 34th week of the year. So in terms of the monthly distribution, consistent with what was happening in the rest of the country, as well as what you saw in Ngami, our peak was in February, and then we went on a downward trend, and then we saw another surge in July, and we are hopefully now on the downward trend in terms of the cases. So COVID-19 has affected all age groups in the district, but most importantly, it has affected the mobile and young population. We noticed we had several outbreaks in schools affecting 10 to 19 years old, and we also have cases affecting other age groups up to age 99, but most cases were confined between the ages of 10 and 49 years old. And you can see that the females are affected more than the males in this graph. Gomolemo has been the epicenter of COVID-19 cases, and they experienced their highest peak in August, where we registered 524 cases, followed by Shakawe with 198 cases. We also had some sporadic outbreaks and high attack rates in some of the small villages from time to time. Villages like Beta had cluster of cases in the schools. Villages like Habu, they also had some sporadic outbreak and cluster of cases in the village, as well as Ngomogao and in Seronga as well. COVID-19 also affected our healthcare workers similarly to what is happening in Ngami and the rest of the country. We had 99 healthcare workers that were affected by COVID-19, and the most affected cadre was the nurses, with 29 nurses being affected by COVID-19. We lost one midwife, and the other cadre that was hard hit were the drivers and the cleaners as well. In terms of mortality, even though I said that we had 32 deaths, that was as of the 24th, but this was compiled before the 24th. At that time, we had 28 deaths. So of which 11 of them were brought in dead, and 17 died in our facilities, JP, and one in Gaolathe, and the others succumbed at Sekitumila Masire. In the last week presentation for the country, the country report, EP report, indicated that Okavango had the highest community deaths. And we started noticing our community deaths from January, going into July mostly. And we also noticed that most of the deaths, they were coming in, they were not diagnosed prior to succumbing to COVID-19. So most of them were swabbed as BIDs, and then we found out that they had COVID-19, majority of them, except I think the two of them that we knew that they had COVID-19 prior to their passing. So in terms of mortality, even though COVID-19 has affected females more than males, our men are dying more than the females. So we have more deaths affect the elderly more than the young people. We only have 3 deaths under the age of 40. The reason why it's like I'm not able to see my screen very well, so I don't understand what's happening. But at least I know because I did the presentation. You can continue. Okay, I mentioned that we work with environmental help from local government. So they do monitor our facilities in terms of the schools, compliance to COVID-19 protocols, and the establishments, the business community. And they do that on a weekly basis and compile monthly reports for compliance. As you can see, from January, the compliance has been ranging between 63, hovering in the 70s, and 98.8 in January. I must say that even last year, our compliance in the establishments for COVID-19 protocols was very good. And as we did our contact tracing, it became evident that most of our cases are really not emanating from facilities or establishments or the business community itself, but they are basically community. The infections are acquired in the community because the positivity rates were much higher when you go out and do the contact tracing in family members or friends, as opposed to co-workers, unless those co-workers are friends. In terms of law enforcement has a component of immigration. I mentioned that we have one port of entry that is currently functional. We had 2,503 cases, arrivals and departures at that port of entry since March last year. They also monitor compliance in terms of the law, the public health law, to COVID-19 protocols. And we have encountered 3,056 cases, and most offenses that were committed were failure to confine to place of residence, that's violation of the curfew, failure to wear masks in public. People still have issues with wearing masks in public, and unlawful gatherings, what we call the chill sessions, and those gatherings that you find after the funerals, and also selling of brewing and traditional beer without permits. Just like in the rest of the country, Okavango DHMT has commenced its vaccination rollout. I mentioned that our projected population is 71,727. Our sub-district target, however, for 18 and above is 50,000. We have 37 vaccination sites. Most of them are stationary, even though sometimes we have mobile teams that move around the districts to vaccinate. Most of our vaccination sites are our quotas and our some structures in the districts, like the VDC hall in Shakawe and the bus rink in Gumare. We have some sites that have not been activated yet because of the shortage of vaccines that we have in the country. However, we are hoping that we're expecting that when we receive more vaccines in the district, maybe we'll open some more sites, especially in the big villages like Shakawe and Gumare. We have 37 vaccination teams that are corresponding to the vaccination sites, and the district is divided into 10 clusters. In terms of our performance against the doses received, in fact, we have received 3 doses. We have received AstraZeneca and Sinovac and Johnson & Johnson's. We started with AstraZeneca in April. We inoculated 1,043. Unfortunately, our coverage for those that are fully vaccinated stand at 83% now because the second dose progression has been very slow. DHMT to see if we can mobilize those doses to them, because it's very difficult for us to convert them into first doses when we can't guarantee that they will get the second dose, as well as the fact that the doses will be expiring in 2 months. So if we are still stuck with them now and they can be utilized somewhere, then maybe the best decision is to mobilize them to a district that can actually consume them. Fortunately enough, for Sinovac, we are not having a lot of problems. I think for second dose, we managed to cover 96% with Sinovac. I think maybe it's because the time interval between the first dose and the second dose for Sinovac is not that long. But for J&J, you get 1 dose, you are fully vaccinated in 2 to 3 weeks. So we are standing at 2,224 fully vaccinated as it is. And as for the total that are fully vaccinated in the district, we're at 8,646, which is 93% of the doses that have been received so far. So we had our district targets for about 55 and for healthcare workers. Our target for about 55 was 6,232, but we vaccinated 5,353. That is about 85%. And for healthcare workers, our target was 855. We vaccinated 574. That is about 67%, consistent with what we are seeing nationally. I'm not sure why we are this low in the district, but we do encourage healthcare workers to be vaccinated. I must also say that our staff list is about 597. So those are PNP employees. The 855 comes from the addition for the TSPs, the volunteers, security guards, and other carriers that are working on temporary basis. So in terms of our successes, we were able to open our JP Kabindama 20-bed isolation this year in February. And we also opened our COVID-19 PCR lab in Shakawe, which is currently operating, even though it's low capacity. We're able to train in decentralized contact tracing with RDTs across the district. So any Motswana anywhere in Okavango sub-district is able to access testing wherever they are, if there is a facility in that local, provided the tests are available. And we are able to deliver vaccines to all villages and all settlements with the help of other stakeholders. And we are also able to maximize utilization of our data system, because we need to be utilizing DHIS all the time for real-time reporting and also for self-registration. So in terms of our challenges right now, the biggest challenge is the stockouts for rapid antigen testing kits is hindering our contact tracing and our testing in general and our diagnosis in general. We have limited bed capacity for isolation, even though our occupancy rate is so low. It's because we have very stringent admission criteria, and we are forced to have that one because we have very limited bed capacity. We only admit those that are requiring oxygen, those that are over 65, some under 5, pregnant women, those that are coming from hard to reach areas. We also have a lack of network connectivity in most areas in the district. We are not able to do real-time data in most of the districts. So our teams that are vaccinating in areas without network connectivity are capturing data manually, and they are forced to transfer the data into the system once they get to where there is network connectivity. We continue to have high infection rates among healthcare workers, and it threatens our quality of delivery of our quality health services and the adequate and appropriate response for COVID-19. So in terms of our next step, like I said earlier, we had, according to the national report, we have the highest number of community deaths, and we are hoping that by implementing our community home-based care strategy, we'll be able to decrease community deaths and increase early case detection in the households. And we want to continue to vaccinate with fidelity to the National Vaccine Deployment Plan, and continue to inspect the establishments using environmental health to strengthen compliance to COVID-19 protocol in the districts, and also maintain community engagement and collaboration through various platforms to increase vaccine uptake and also COVID-19 compliance to protocols. I would like to thank the healthcare workers who are working around the clock in the district to make this possible, from the gatekeepers to the M&E that are responsible for this data, to the nurses, to the doctors, to the drivers, everyone. I'd like to thank them a lot. And to the Sub-District Emergency Operations Center and our main DOC in Maung, they have been very instrumental in helping us with the COVID-19 response. I also like to thank the Ministry of Health and Wellness leadership and the Presidential National Task Force for COVID-19. Thank you.
Thank you, Dr. Moali, and your team for all you are doing. Thank you to your team as well, Dr. Maripe. I think now we can go to the questions. Any questions and comments that you may have for our two presenters today? We had a couple of questions that were submitted on registration, so prior to this session. There's a question that says, are district emergency operation centers still in existence, and who is chairing the committee? I think this is a question for each district. Do you have emergency operation centers in your district, and who is chairing that particular committee? Dr. Maripe, you may go ahead and address that question.
Okay, thank you. We do have the district emergency operation centers, and Ngami and Okavango, they actually make up the Northwest District. And it is through the District Emergency Operation Committee that we are able to meet as the two sub-districts, and it is chaired by the DC. And for the two sub-districts, we still do have our, what we call the sub-DOs, where the two districts also meet independently to discuss their issues. And I would like to confidently say that our DOC is fully functional. We meet once every Wednesday. Thank you.
Thank you so much. Dr. Moali, do you want to speak to that structure in your district?
Thank you for the question. I thought I illustrated our district response in the second slide for my presentation.
Hello, Doc.
Hello, you can hear me?
I can hear you now.
Okay, thank you. I thought that my second slide illustrated our district response. We basically, our district response is spearheaded by the District Emergency Operations Center. We meet every Wednesday, that's the sub. We meet every Wednesday where we meet with other stakeholders. We're the secretariats to the committee, by the way. So we provide technical advice every Wednesday. We sit with environmental health, law enforcement, bylaw, and deliberate on what is going on in all aspects of COVID-19 management. And we also report to the main DOC, which sits in Maum. They are both chaired by the deputy DCs at sub-district level, and at main district level, they're chaired by the district commissioner for Northwest. So they're fully functional. Thanks.
Okay, thank you so much, Doc. Another question, the participant wanted to know the side effects to the COVID vaccine that you have noted in your district. I think they just want to know any common side effects, the common side effects that you have noted so far. Is it only the flu-like side effects, or have you noted any serious side effects? Apart from, yeah, basically that, any serious side effects that you have noted?
Unfortunately, I didn't share that slide, but we have the adverse events following immunization committee that analyzes the data from all the vaccines that we have given. We analyzed the data for AstraZeneca. AstraZeneca, we're delivering it to over 75 initially, and there were very minimal side effects for the over 75. However, once we stepped down to the younger population, because we had to enroll the healthcare workers that worked in isolation, we started noticing that they were experiencing some side effects. I think 2 had allergic reactions to AstraZeneca itself at the site, which was managed, but the rest had some other side effects like the fever, generalized body pains, but there was no associated mortality linked to AstraZeneca. The same thing with Sinovac. Sinovac was much more, we received less number of side effects profile from Sinovac compared to AstraZeneca. I don't know if it's because people had expected it to happen or what, but we didn't have a lot of notifications for adverse events following immunization for that. We are still rolling out Johnson & Johnson, but we haven't had any red flags in terms of severe side effects for Johnson & Johnson's. Thanks.
Okay, thank you so much. We have a hand from Dr. Mokadi. You may go ahead and ask your question, Doc.
Thank you very much. Let me appreciate or congratulate the 2 presentators, Dr. Moali and Dr. Sandra, for the nice and informative presentations, which from which we may also learn something to improve our management of a COVID burden. I want to ask Dr. Sandra, in terms of case fatality rate, actually is about 2%. And I think if it's not the highest in the country, maybe it's the second. Because as a nation, we are standing at 1%, close to 1% case fatality rate. But Ngami alone is going up to 2+%, Okavango 0.9%, which is also close to 1. I would like to understand what is their strategy in terms of 3T of surveillance, which is actually tracking the cases, testing, and isolating them. Because if the surveillance is we have a good surveillance, it means I think it also plays a role in improving the outcome. But how is the testing? Because I got it from Dr. Moali, they've decentralized the testing. So in Maun, I would like to know, is it that all of them, they come at the one site, or even at the facility level, they can test? And in terms of contact tracing, is it done by the facility, or it is actually one site? I mean, is it centralized or decentralized? So another common question, or the question for both of them, is on the mortality. I didn't get any comparison between, in terms of mortality and the vaccination. So I've noticed that there is a high mortality among those above 55. And these are the people who were highly vaccinated compared to below 55. So is it that the vaccination is not working, or what can we tell? Because from the other research outside in Europe or America, or even here in Botswana, our national is showing that the vaccination has a positive impact on reducing mortality and morbidity. But we still notice there is a high mortality among those who are above 55, while they receive the vaccine more than younger age. And again, in terms of mortality, in terms of, the trend in months, to compare to see, is the mortality increasing with number of cases? As you may see, the latest wave where we have a high number of cases, actually June, July. So how is the mortality during that period? I think with that, okay, the last question on the health promotion, Okavango actually. What is the impact of the health promotion? Do you provide anything? But concerning the BID, those dying from home, if I get you well, it's like they are testing after they've been brought and then they found they are positive. But the home-based care strategy, I thought maybe it is going to focus more on those who are positive, following them up. But what about those who have not tested positive, to reduce this BID from home? Thank you.
Thank you, Dr. Mukadi. Okavango, Dr. Moali, you want to respond?
Thank you, Dr. Mukadi, for your questions. I will take some, and then Dr. Maripe will take some. There were many questions. I was trying to jot them down. For community mobilization to combat the BIDs, we have a problem here of people that use a lot of traditional medicine. And so they would go to the traditional healers first and then try to treat and do what needs to be done. And they don't come in contact with our healthcare system until they have succumbed in some way. And we do try to sensitize people on COVID, but it's not as effective as we would have wanted to do it because of the COVID-19. We can only do so much in terms of reaching our community with our community mobilization, but we cannot do that much because we have so many things. Our teams are engaged in so many things, and we are not able to bring people to our kotlas and the congregations the same way we used to do in the past. But it's something that we really need to look into, or even target those traditional healers and educate them on what the importance of making sure that they rule out some of these illnesses before they can actually advise on the treatment for that particular person. And for the BIDs as well, some of them were elderly people that were on community home-based care, the traditional community home-based care. So they were sick, and maybe they did not really have the classic signs for COVID, and the family never suspected or thought that they should be brought to the hospital to be tested for COVID or something like that. So we think that maybe that is why we're receiving them in that state. I do understand your concern that the community home-based care strategy is not going to address this problem. I also believe that partly, but I do believe that based on the profile of the deaths that we have registered and the fact that they were at home and they were somewhat sick and bedridden, some of them were bedridden, some of them were elderly. If there is a COVID-19 positive case in that household, that is known. And when we do the active case finding, maybe when we swab everybody in the household, we'll be able to pick them up as well. So that's what I'm thinking maybe it will help us in some way to implement it. And then the other question was on mortality for the 55 and above for those that are vaccinated. When we analyzed our data, the ones, we never had a death of a COVID-19 patient that was fully vaccinated due to COVID-19. I mean, somebody dying due to COVID-19 and they were fully vaccinated. We never had that. So those cases that died were not fully vaccinated of COVID-19. So it's very hard for us to have a concrete conclusion as to whether the vaccine is effective, is working in our population, until we see or we have clear data that these persons are fully vaccinated and they succumb to COVID-19. Thank you. I hope Dr. Maripe will help me with the other ones.
Thank you.
Yes, thank you so much, Dr. Moali. Emma, we may go ahead. Thanks.
Thank you very much. Thank you, Dr. Mukadi. In addition to what Dr. Moali had said, we were also able to do the analysis of our mortality cases at the time when we started the COVID-19 vaccinations. And for Ngami, we had a total of 78 deaths from the time we started vaccinations in April to date. And from that number, only 3 were fully vaccinated, and 8 only had received their first dose, and the 67 were not vaccinated at all. I think in addition to what also Dr. Moali has said, as much as we were offering these vaccines to our community, we should also remember that it is not yet so mandatory, or patients are not forced to get, even now when we are in the phase 2, we are still seeing clients who are elderly who still haven't received their vaccinations. In terms of the mortality as well, during our third wave, I would say that our were increasing, particularly testing. Initially, when we started, our testing was centralized, but we have now since trained all the facilities in our district. So each clinic does have officers that have been trained on COVID-19 testing. But for our experience, particularly in Maung, when we're in the third wave, we noted a high number of contacts of the indexes who were coming in large numbers, and we were forced to re-centralize testing centers because our facilities were overwhelmed with the normal services in addition to the COVID-19 vaccination. And some facilities were actually unable to offer the testing due to the large number of volumes of patients who were coming for testing. And for contact tracing, for Ngami, our contact tracing is centralized. We are currently having 7 teams which are fully operating on the ground. And it is also for the same reason that we decided to centralize it, because at facility level, due to the critical shortage of staff, we realized that it was not being done very well. So we decided to form these teams which are fully under contact tracing, and they're the ones who are doing the contact tracing, and they report to the rapid response team. We also have a very active RRT group on WhatsApp, where the such feedback is provided on in real time. I think that's about it. And he was also right to say our case fatality is the highest in the country. So we were actually topping as per the last report from the national office. Thank you.
Emma, thank you so much. We have come to the end of our session today. Thank you to both presenters. Dr. Maripe, there's a question for you in the chat. I think you can take a look at it and respond there in the chat. Dr. Gaolathe, any last words?
Yes, good afternoon. Just one announcement. Vusindaba, who's our administrator for the webinars, will be sending out a questionnaire. And please, if you could help and send back the responses by Tuesday. This is really on his part trying to gather information on these webinars, what you find useful, what you'd like to hear, or what would like to have presented. So next week's session, we have a presentation from our own Dr. Dinalo Molefe. She's a respiratory consultant at Peterborough City Hospital in the UK. So for her topic for next week, she will be discussing COVID-19 related venous thromboembolism. So I think this is an interesting topic, especially for those who are in the clinical space. With that, thank you for joining to respond to the questionnaire that you will receive in your mailbox. Feel free to share it with those also who have attended any of our webinars, and we will meet next Thursday. Thank you.
Thank you, everyone. Bye.